Thank you for this invitation. I'm really glad to participate in this educational meeting. And I will speak on modulative manipulation of pain in the failed back syndrome. I have no disclosures. And as you can see, there are different ways to speak about the same problem, that it's an heterogeneous group of patients with persistent lumbar or sciatic pain after one or more lumbar surgery. So let's talk just a few minutes on pain. As you can see, the International Association for the Study of Pain describes pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. So there are unpleasant sensations. The patient feels some unpleasant feelings like depression, anxiety, and anger. And the sensations and the feelings, unpleasant, leads to consequences not only for the patient, but also in his relatives. So consequences in the physical and the psychic and social health. But why is it so difficult to describe pain? Because it's a multidimensional experience. There are neurophysiological, biochemical, psychological, etc. issues that are involved. So when you are dealing with chronic pain, you need a multidisciplinary approach. And we as neurosurgeons treat mainly chronic or persistent pain. As you can see, there is a physiological, let's say, pain, that is a nociceptive pain, and there is a neuropathic pain. We are going to speak on neuropathic pain, of course, when there is a lesion or dysfunction of the pain signaling pathways from the central peripheral nervous systems. So, as you can see, there are different and several etiologies for failed back surgery syndrome, but mainly I can show this epidural fibrosis and arachnoiditis. And unfortunately, in the last few decades, the more often and more frequent spine surgery, and unfortunately, as I said, led also to iatrogenic and incorrect surgical techniques or indications. So this is a very frequent picture. Unfortunately, that's this. It's even a very simple procedure like a microdiscectomy or a MIS discectomy or full endoscopic discectomy can produce a scar, a tissue that fibrosis or arachnoiditis, and the patient will keep on suffering pain. And of course, it's more frequent, as I told you. This picture of a iatrogenic surgery, like this positioning of the pedicular screws, and this cage, interbody cage, that it's out of its place. And of course, malpositioning of the screws, pedicular screws that are really foraminal screws that are lesioning the nerve roots, or again, a malpositioning of the screws and the cage, and this picture, and this pain, persistence of pain in this patient. So what are the complexities in managing a failed back surgery syndrome? This is the States, you can see in 2020, where you can see that for 200,000 lumbar spine surgeries, they show that nearly 20 or 40%, up to 40% of patients, they still have some kind of post-operative pain. And of course, that it has an impact on the economy and the healthcare. Again, in the US, you can see that in the 2020, they spent more than $100 billion. So what are the options of treatment for these patients, these difficult patients? Of course, medical treatment or conservative treatment, reoperation, and finally neuromodulation. And we have to credit this man, Norman Gilly, that short after the Melsangan-Wall description of the gate theory, he published this paper showing the impact of the electrical inhibition by stimulation of pain by stimulation of the dorsal columns. And just to show you what can we do with the neuromodulation, when there is a lesion, there is in the central nervous system, an apoptosis of the inhibitory interneurons. They begin to appear new synapses with A fibers, and then there's an opening of new channels from NMDA, from calcium and sodium at the dorsal horn neuron. So this situation of sensitization, synaptic organization, and disinhibition explains the hyperalgesia and allodynia as main symptoms of neuropathic patients. So let's compare the best medical treatment with neuromodulation. And this is a multi-center randomized controlled trial with a few very well-known functional neurosurgeons. What they show it was very clear. They stated that spinal cord stimulation is far better or more better than conventional or medical treatment. And this paper published a few years ago by Richard North in Chicago, it's a double-blind study, randomized, controlled, where with two arms, 42 participants, one surgical or arm, and the other it was a randomized, spinal cord stimulation arm with the possibility of crossover. And you can see that the final result of this trial is that most of the patients that were randomized for neuromodulation, they did well, and many or most of the patients that were reoperated, they crossed to the neuromodulated arm. So what is the current continuum of care for fade-back surgery syndrome? As there is the diagnosis, the correct or proper diagnosis as the first phase. There are conservative treatments, and then in the third and fourth phase, you find the ablative and then neuromodulation procedures. And Kumar, a few years ago, showed also very clear that the sooner the better. And you can see here the patients that are operated or neuromodulated 2 years, less than 2 years before the diagnosis, they have more than 80% of success rate. And the patients that are operated more than 10 years after the diagnosis, they have less than 10%. So the sooner, the better. And we can propose a new schema of treatment where spinal cord stimulation or neuromodulation is not the last option, but it's really it's the best option as soon as possible. And what are the approaches? There are the standard approach that is a single or double column, as you can see here. Everybody is familiarized with this picture, and we published this paper showing that the position of the tip it's very important, depending on the pain location, but also we do in every case, of course, a neurophysiological location as well. And but many patients do not well for the back pain with this simple approach. So the issue is that it's an anatomical issue that the back fibers, they are more lateral, as you can see here. And so to reach the fibers, you have to be very straight to the lateral, laying lateral to medial. So with a single lead configuration, you deliver a very high dose of electricity just to reach this point. So you can have, of course, complications. With a dual lead configuration, with an anode and cathode, it's a little bit better, but still it's not the best configuration. And when the transverse tripolar array arrived a few years ago with 2 anodes and 1 cathode, you can deliver a best amount of energy or electricity, but it's still, there are patients where it doesn't work. So there is another possibility, that is a 5-column neurostimulation, where you can make a very meticulous stimulation of the different parts of the dorsal spinal cord. And this is one case showing this system. And another options that have been studied are, for example, a peripheral nerve or peripheral nerve field stimulation, where you are stimulating subcutaneously. And there are some papers showing this modality of stimulation. The crosstalk peripheral nerve stimulation, that it's the possibility of using an electrode as cathode and another electrode as anode, and so the target is in between. And there are some papers. And finally, the hybrid nerve stimulation, where you combine classical spinal cord stimulation with peripheral nerve stimulation. Also some papers showing that the usefulness of this modality of neurostimulation. So the parameters of stimulations, there are usually a frequency of 60 hertz, and the pulse width can vary, can be different. And there's the group of Newton in Belgium. He published this very nice paper showing that how can you change the pulse width, and you have a different coverage of the fibers, of small fibers or large fibers for stimulation. And this is a very safe, of course, procedure, surgical procedure. The complications are not very often. The most frequent is electrode migration. But you have to think that every patient is different. And as I told at the beginning, you need an individualized approach. And there are new modalities that have arrived, like high frequency spinal cord stimulation, more than 10 kilohertz, so more than 1,000 hertz, 10,000 hertz, sorry. We are using, has been using this modality for a few years, and it's very good for the patient. And also we can build some mathematical model where we can work with the separation with the anode and the cathode. As you can see in this picture, it's also interesting for the treatment of failed back surgery syndrome. But what is the most recent advances in neuromodulation? I think one is the burst stimulation that has been shown very straightforwardly by the Sunburst study, that this sort of this type of stimulation, the burst stimulation, is better than the tonic stimulation for the patient, and is safe. And finally, the DRG, or dorsal root ganglion stimulation, that has been shown also a very good results, mainly for complex torsional pain, syndrome, and causalgia. So as I have showed you very quickly, we have different tools to use to treat our patients. But since the miraculous stop pain pill arrives, I hope sometime in the future, I don't know if I will be there, we have to think as neurosurgeons in the best way to treat each of our patients suffering for this difficult disease that it's the chronic pain. So thank you very much.